money is not a problem. Earlier people were thinking that rhinoplasty or any cosmetic surgery, it attracts too much of price. But nowadays, everybody is having money. Everybody wants to spend on their features.
Ladies and gentlemen, welcome to another episode of the Rhinoplasty podcast with me, Dr. Cameron McIntosh. We're in the month of August with our special panel of international experts brought to us by Pentax Loops. So shout out to Pentax Loops, incredible loops, bringing us incredible people to the show. So on the show this week, all the way from Mumbai in India, none other than Kapil Agarwal. Kapil, welcome and thank you so much for being with us today.
Thank you very much, Dr. McIntosh.
So, Kapil, we've had a lot of interaction over the last couple of years, and you guys were fantastic on the World Rhinoplasty Day, the team that you guys put together. For the listeners out there, my first question to you is, where did this journey of rhinoplasty start for you?
It started actually during my residency in way back, I think 20 years ago. When I joined my residency in plastic surgery, my teacher, Dr. Bhatt, he was very passionate about doing rhinoplasties. But mainly he used to do closed rhinoplasties. But he was the one who actually introduced me to the word of rhinoplasty. And maybe I might had something in my mind earlier, which I got completely involved in that procedure. I could not do much that time, but I only observed. Not only my teacher, I used to attend all conferences and other surgeons. The work of surgeons. I saw the work of surgeons, and I got so involved in that. Every person, every second person, I used to look at the person's nose and kept thinking that kept analyzing the problems, kept making plans and mock surgery in my mind. So when I did my first surgery, it was not very much new for me. So I had done so many surgery in my mind earlier. So during my residency only, I got involved into rhinoplasty.
And I mean, India has a population the same size as the African continent. It's massive. And in ancient writings, the first forehead flap came out of India. I mean, you guys, the facial plastic surgery and rhinoplasty has been for hundreds of years in India. How big in the country is rhinoplasty?
It's coming up actually. Earlier only celebrities were getting it done, but nowadays the common people are also actually seeking rhinoplasties, and I think every passing year it is increasing in number. Not like West, but definitely it is increasing. So now actually in last 5 or 6 years, as the name of the surgeon is spreads here and there. And actually, my total percentage of surgeries is almost 75% of my surgeries is rhinoplasty now. Earlier I was doing everything. Now it's rhinoplasty only. So quite a few cases I get, and not only myself. And in India we have around 2,000 plastic surgeons. I think everybody is doing rhinoplasty. So number of rhinoplasty every time increasing. People look at others' face and they feel that this fellow has got this surgery done and is looking very good. So they also come. Now actually money is not a problem. Earlier people were thinking that rhinoplasty or any cosmetic surgery, it attracts too much of price. But nowadays everybody is having money. Everybody wants to spend on their features, looks.
And okay, so changing the subject very slightly. Kapil, are you still depressed about South Africa beating the Indians in the latest 5-day tests here in South Africa? How's the mood in India? Are they a little bit sad still or not?
After COVID, you are asking?
I'm saying the South African cricket team. beat the
Yes.
Indian cricket team in a recent test series. What,
It,
you
it,
don't want to
it,
talk about that, eh?
no, it's part of it. It's part of the game. Sometimes you beat us, and sometimes we.
I think most of the time you beat us, so that's why we're
No,
very happy to
not
win
like
once
that.
in a
Not
while.
not like that. Some home advantage is there, and at that time I felt that our team was not up to the mark.
Okay. Anyway, jokes aside, Kapil, what do you? I know you're super passionate about rhinoplasty education, and you give a lot of talks. You guys are really like with COVID. There were some amazing congresses, virtual congresses, etc. that you ran. What is your motivation behind that?
I really don't know. I don't know. Maybe yeah, love for rhinoplasty. God has given something to me, or maybe I'm born artist. Since my childhood, I'm painting, crafting. That might have got this one more attraction towards features and all.
Okay, so
Keep doing that.
I know we're going to be climbing into an interesting topic just now, but I wanted to ask you, what do you do in your free time when you're not doing rhinoplasty?
I sit at home, uh, spend some quality time with my family, help my wife in kitchen, and go to market, buy some household things like vegetables and groceries, etc., and some house cleaning, etc. So mainly I'm at home whenever I'm not doing anything.
Okay, Kapil, thank you so much for that very interesting chat we've just had. I'm really looking forward to hearing what you have to say about ALA-based management. So if you don't mind pulling your slide up and sharing it with us, then we'll be able to see and hear what you want to share with us.
Yes, can you see now?
Looks great. Please go ahead.
Yeah. So I will be presenting my technique.
LR-based modification is
This is the LR-based management technique where I am cutting only skin and I made one LR rim triangular flap.
LR-based modification is a very tricky and scary step in rhinoplasty. The need of developing this technique were my own fears, the loss of convexity of LR or developing a straight LR, compromising the blood supply while in doing the open rhinoplasty, cutting blood supply from both sides, from columella as well as from LR. And in cases where I go wrong, either in planning or execution, would I be able to reverse the procedure without much scarring and deformity? Literature gave me all answers, alleviated all my fears. We see the anatomy of LR. The LR lobule contains no cartilage, consists of skeletal muscle and fibrofatty alveolar tissue that is enveloped by dermis and epithelium on both the sides. Blood vessels run over or within the muscle layer. The forces responsible for the convexity of LR lie in fibrofatty tissue and the vestibular lining. Based on these informations, I modified my technique. The first change I made in the depth of the excision. Here, instead of cutting full thickness, I chose to excise only skin from the marked area, which avoids loss of convexity of LR by preserving the forces lying in the fibrofatty tissues and vestibular lining. Preserve the blood supply of LR, and wherever the reversal of procedure is required, it has become very easy and predictable, as this excised skin can be used as full thickness graft. Second change I made in the design of the excision, and instead of cutting straight, I designed a triangular flap over the LR rim and limited my excision to the sill and created this triangular or inverted triangle or inverted V over the sill to receive this triangular flap. So when this triangular flap is fed into the sill, it recreates normal LR base and deepens the LR facial groove. You can see here, and then maintains the continuity and prevents the acute deformity of the nostril, and it decreases the chances of scarf contraction and stretch. Here in the standard technique, one has to suture inside the nostril. This thin LR rim becomes the LR base, which looks unnatural, and this rim meets the sill in an end-to-side manner, and the more chances of creating acute deformity.
Here is the marking, the lower marking right in the facial groove, and the triangular flap, inverted V in the sill, infiltrating here, being triangular flap, excising only skin from the marked area. It can be cut by a knife or pair of scissors, feeding the triangular flap into the inverted V of sill, and the incision can be closed with the 6-0 interrupted sutures.
A semi-lunar incision. A semi-lunar incision is being marked. The lower marking is right in the alar facial groove. A temporary straight line is drawn from upper marking to help mark an isosceles triangle on the alar rim. Both the upper and lower marking are meeting over the sill as an inverted V. Now incision is being taken. Only skin is removed from the marked area. Both sides skin is removed. Now the triangular flap is being fed into the inverted V over the sill, and closure is being done with interrupted sutures. This is the final.
Elliptical excision is the wrong method. It creates a natural straight line closure. Semilunar excision is the right way of excision, producing natural LR facial groove, and one has to follow the design of the natural LR facial groove to have natural result. Clinical examples of wrong excisions. In this first, excessive LR excision has been done with a straight line closure. And in the second one, the excision has been done 2 mm above the LR facial groove, and somehow this doesn't work in Indian patients. Strictly no massage should be advised in the LR facial groove after LR modification. Overzealous massage in LR facial groove widens the scar, and a well-hidden scar will be evident. Come to the clinical cases. Boxy tip with LR axis, frontal view, and here you can see the scar appears just like a shadow you can see in the pre-op picture. And on basal view, the normal LR base is recreated, LR facial groove is recreated, and here the teardrop shape of the nostril is maintained. The other case is broad nose and LR axis, frontal view. Inside, the scar is well hidden into the LR facial groove, and base looks absolutely normal. recreation of LR facial groove and the shape of the nostril. Here the LR axis, no visible scar, and LR base, LR facial groove and nostril shape looks normal. In other augmentation rhinoplasty or any aesthetic rhinoplasty, you may need to do the LR modification. Frontal view, and in this view, oblique view, you see the scar is just like shadow of the pre-op photo. Base looks normal, LR facial groove is recreated, and nostril shape. Other case with LR axis, frontal view, same result. Good LR base as well as LR facial groove. I conclude here, the skin-only excision and triangular flap technique has made this one of the trickiest steps of rhinoplasty a simpler one, very easy to understand and simple to reproduce, preserve the natural LR convexity, LR facial groove and angle, recreates normal LR base, continuity of seal maintains the normal shape of the nostril, producing natural results with well-concealed scars, and reversal of procedure has become more predictable and with minimal scarring. And this is a procedure of millimeters, subtlety and conservatism are paramount.
Hey, namaste, Kapil. Thank you. That was a great presentation. Can I ask you this question? In the presentation, you were showing most of the time bilateral ALR-based reductions. However, we know that clinically, sometimes one nostril is more asymmetric. Do you sometimes only do one, or do you do quite asymmetric removals?
Yeah, I have found many LR asymmetric, but I have not done only on one side in aesthetic rhinoplasties. But I have done 3 cases of vascular malformation as well as a neurofibromatosis in which only one LR was involved. So it can be done on one side also. It's not a problem.
Okay. One more question for the junior listeners. There's guys from 70 countries and around the world listening to this. What is your advice in terms of someone who's seriously considering rhinoplasty in their practice?
My advice, first he has to be very very passionate about this whole procedure. First thing, he should have that passion to go into the rhinoplasty, and then start from the basics. First read the basic rhinoplasty procedures, incisions, etc. And then keep observing your mentor, whoever you are following, and then go for basic. First the basic rhinoplasty. In India, the basic rhinoplasty is augmentation rhinoplasty. Initially, when a patient comes only for augmentation of dorsum, so that is the easiest one for them to learn initially, and then on that they can build the rhinoplasty later on. The first thing they should do only a small thing, only augmentation of dorsum. Later on they can go for a small thing, the tip, and other things later on when these post-traumatic rhinoplasties or cleft rhinoplasties or crooked rhinoplasty, they should come later in practice, not in the beginning of the practice.
Well, Kapil, thank you, man. On behalf of the listeners around the world, huge shout out to you. Thank you for the effort you've put in, your clear passion of wanting to teach rhinoplasty. Also, a shout out to Pentax Loops, who've brought this month to everybody around the world. We appreciate it. And may you have a wonderful rest of your day. And thank you for being on our show.
Yeah, thank you very much, Dr. Cameron, for inviting me to share my experiences, to my views on rhinoplasty. Thank you very much.